Hi, my name is Kirsten Walskog, and I am currently one of the PGY2 Critical Care Pharmacy residents at Freighter in the Medical College of Wisconsin. And today I will be talking briefly about the acute bleeding management in Jehovah's Witness patients. Today I have two learning objectives. By the end of this presentation, you should be able to list blood products that Jehovah's Witness patients may not accept and describe key principles for managing acute blood loss in Jehovah's Witness patients. I cannot speak for every single Jehovah's Witness patient. However, the religious beliefs amongst Jehovah's Witness patients regarding transfusions is generally in that they do not accept whole blood or any of the four major components such as red blood cells, platelets, white blood cells, or plasma. However, some patients may accept blood fractions such as albumin and coagulation factors, and this is something that should be discussed with the patient on an outpatient basis, in addition to the inpatient basis. Autologous blood transfusion is generally considered to be unacceptable unless the blood is in a continuous loop that circulates back into the patient so that the blood remains in continuity with the body for the entire duration of time, such as with hemodialysis or cardiopulmonary bypass. It is strongly recommended that Jehovah's Witness patients and their providers have a pre-hospital checklist that they go through before the patient is admitted for potential surgeries. It is important to screen for anemia prior to that surgery or any sort of other intervention that may be associated with blood loss. And we should always discuss and document acceptable products with the patient and their family, especially as some patients may be willing to accept some of the coagulation factors and others may not. If undergoing some sort of a surgery, the primary surgery team and anesthesiology team should pre-screen the patient to have a pre-planning checklist. And for some patients with high-risk bleeding procedures, it is also recommended to consider a hematology consult before they come to the hospital. However, with most of our ED patient population, these patients are not coming in for a planned procedure and is often an emergent or urgent basis. When looking at guidance in the literature for management of acute bleeding in Jehovah's Witness patients in the ED setting, there really isn't very much out there. It's mostly case reports and expert opinion. There is some limited information in some of our pre-planned procedure populations such as obstetrics, cardiac surgery, and other planned surgeries such as orthopedics. However, we can only somewhat extrapolate this literature to the patient population in the ED setting. Despite the lack of literature, there are three main key principles for managing acute blood loss that most of our interventions fall under. It is recommended that we simultaneously complete the following, which includes reduce further blood loss, correcting coagulopathies and enhancing hemostasis, and improving red blood cell production. We can do several things when the patient initially presents to the ED to avoid blood, such as resuscitating with IV fluids and vasopressors if needed to obtain hemodynamic stability. We can also minimize blood draws by using pediatric tubes and also drawing all of our labs all at the same time to avoid that phlebotomy. Additionally, it is important to investigate the source of bleeding using imaging, endoscopy, or surgical intervention. And we can always consider certain therapies depending upon the site of bleeding, such as oral contraceptives or IV estrogen for abnormal uterine bleeding, or other topical therapies if appropriate, such as hemostat. Moving on to the second portion of managing the bleeding, which is correct coagulopathies. So based upon the patient's individual labs and their acceptance, we can consider vitamin K and PCC if the patient is on warfarin or if they are on a DOAC medication. Additionally, we can consider Tranexamic Acid or recombinant factor 7 for additional hemostatic therapies. I will note that the recombinant factor 7 dosing that is available and is recommended by most centers who do a lot of bloodless medicine and treat these patients generally do recommend using the lower dosing of 45 to 60 micrograms per kilo rather than the full hemophilia dosing of 90 micrograms per kilo. Additionally, if bleeding is more minor, we can consider desmopressin as well to help stop the bleeding. There is some few case reports out there to support its use. Additionally, encouraging the normothermia of the patient is important, and holding all medications that may inhibit clotting, which includes antiplatelet and antithrombotic agents. In taking a little bit of a closer look at tranexamic acid, there is not really much literature in terms of specifically in the Jehovah's Witness patient population. However, I would like to mention that there is evidence for use in trauma patients, which was in the CRASH 2 trial, which was published in 2013, which was a randomized placebo-controlled trial that looked at tranexamic acid at 1 gram over 10 minutes, followed by another gram over 8 hours in acute bleeding trauma patients. And in this pretty large study of over 20,000 patients, they found a reduction in mortality associated with the use of tranexamic acid when used within 3 hours of that injury. And that since it may be effective in trauma patients in general, we may be able to use this in our patients with Jehovah's Witness, given that we know that this study was not specifically in that patient population. Recombinant factor 7 offers a unique drug therapy option for patients who are Jehovah's Witness, since it is a recombinant hemostatic agent that is produced by hamster cells and is not of human origin. There are several different case reports that show success in a lot of our different emergent bleeding patient populations. You can see on the slide several different patient populations. And there are case reports going up to that full 90 micrograms per kilo dosing that I mentioned a couple of slides ago, but in general I would recommend a 45 to 60 microgram dosing for patients with severe bleeding. There is one study that is published in 2013, which was based upon the Australian and New Zealand hemostasis registry that looked at recombinant factor 7 specifically in the Jehovah's Witness patient population. This was a retrospective analysis of their registry of all different products that have been given to patients over 10 years. And they retrospectively analyzed patients who were Jehovah's Witness and compared them to non-Jehovah's Witness patients. As you can see, some of those patients who are Jehovah's Witness did receive blood products, and it's thought that perhaps some of those patients, it was not known that they were Jehovah's Witness until they had already received blood products. I will note on the table on the slide, as you can see, patients in the Jehovah's Witness patient population were less likely to be hypothermic and acidotic, indicating that they were more likely to get recombinant factor 7 earlier on before progressing into that severe bleeding stage. Additionally, if you look at the bottom 3 lines of the table, you can see that there's no difference in recombinant factor 7 response, which was indicated by cessation of bleeding or slowing down of bleeding, and there was no difference in 28-day mortality or thrombotic events. However, I will say there is still a 10% risk of thrombotic events associated with recombinant factor 7 in this patient population, so definitely still a risk to consider when thinking about giving recombinant factor 7 to a severely bleeding patient. Moving on to our third key principle in managing acute bleeding, which is improving that red blood cell production. So if indicated by patient-specific labs, we can consider giving iron sucrose, folate, and cyanocobalamin, especially if the patient is having a severe anemia, but not necessarily severe hemorrhage. Additionally, epoetin alpha can be considered in non-critically ill patients, and I say that just because it has been shown to have worse outcomes when used in the critically ill patient population. However, when thinking about all of these agents to help improve red blood cell production, it's also important to keep in mind that it does take 1 to 3 days for these to really start working, so it's not going to be an immediate fix for your patient. Hemoglobin-based oxygen carriers were developed via the polymerization of human or bovine hemoglobin, and these agents were used to help bridge the gap between a life-threatening anemia and the onset of action of agents such as erythropoiesis-stimulating agents, iron, cyanocobalamin, and folate, some of the things I mentioned on the previous slide. These agents were initially developed in the 1990s, specifically to help for this Jehovah's Witness patient population and also as a blood substitute. However, in the early 2000s, a meta-analysis found these agents to have an increased risk of MI and death. So these agents were subsequently pulled from the market by the FDA. Hemopure is one of these agents that is a polymerized bovine hemoglobin and is available in several other countries. And here in the United States, it is available under the Expanded Access Program. So there is a process by which you can go ahead and obtain this product specifically for Jehovah's Witness patients. Although right now through the Blood Center of Wisconsin we are not actively enrolled in this program, when I talked to their members, they said that if we were interested, that Frater and the Medical College of Wisconsin could pursue a further investigation of enrolling in this expanded access program. And I do also want to mention this class of agents because currently now there are several different agents in the pipeline that are kind of second generation hemoglobin-based oxygen carriers. So we may see this technology again in the future. As a summary for today, there are 3 core principles to consider in the acute bleeding management of all Jehovah's Witness patients. And that is that you want to reduce further blood loss, correct coagulopathies, and then improve the red blood cell production. In the bottom half of the slide, you can see that there is a table which categorizes different interventions that may be considered depending upon the anemia and hemorrhage for the patient. So starting on the left-hand side, if patients who are severely anemic but not necessarily having severe hemorrhage, such as a patient who had a slow bleeding GI bleed, this would be a patient population which we could consider starting iron sucrose, folate, cyanocobalamin, epoine, or even our hemoglobin-based oxygen carriers up front early in the ED setting. If the patient is experiencing moderate hemorrhage, then we can consider vitamin K if they're on warfarin, desmopressin, or other topical therapies if applicable. And then moving on to our severe hemorrhage, we can consider everything to the left in addition to considering vitamin K and PCC if on anticoagulation, recombinant factor 7, and tranexamic acid. And this would be for the patient populations such as trauma or other severe bleeding. Thanks so much for listening. I hope that you learned a little bit about the acute bleeding management in Jehovah's Witness patient population and that you can carry this forward into your practice. Thanks. Have a good day.